Good morning, everyone. Delighted to be with you today. Before our panel starts, I just wanted to do a little bit of level setting at Allison's request. We at CUPA use the term pre-approval access to refer to all mechanisms for access to investigational medical products prior to approval, including clinical trials. Through the next 2 days, you will hear the term compassionate use, which gets used in many contexts, but throughout the conference, we will largely focus on expanded access. To quote FDA's website, expanded access is a potential pathway for a patient with a serious or immediately life-threatening disease or condition to gain access to an investigational medical product, drug, biological, or medical device for treatment outside of clinical trials when no comparable or satisfactory alternative options apply or are available, rather. They go on to list some requirements, which means that the patient cannot be enrolled in a clinical trial for whatever reason, that the potential patient benefit justifies the potential risks of treatment, and that providing the investigational medical product will not interfere with investigational trials that could support a medical product's development or marketing approval for the treatment indication. We will talk also about clinical trials today, reflecting our interest in access to novel therapies before regulatory approval, both inside and outside of clinical trials. And while the conference is mainly US focused, we'll have some international speakers. And as Allison mentioned, you can reach out to anyone with a purple dot for questions on terminology or anything else that might come up. With that, we're going to move on to our panel, which is what is the business case for or against expanded access? And I'd like to have the panelists introduce themselves. You can start with Rachel, please.
Good morning, everyone. My name is Rachel Harrison, and I'm from Argenx Pharmaceuticals.
You need to get closer to the mic.
Can you hear me better now?
Can you hear me now?
Hello?
Right.
Okay. Is this on? Thank you.
Thanks, Ken.
Thank you, everyone. Okay, better. My name is Rachel Harrison. I'm from Argenx Pharmaceuticals. I spent the first 18 years of my career in academia, and since in the last 7 years have been part of small pharmaceutical companies. I've had some unique experiences working on transitions from a commercial product, and that has been a really valuable trip for me. The Global Alliance piece of my journey has also helped open up the different situations that could present for small pharmaceutical companies if they were to partner with other companies. So thank you for having us today.
And from a large company, we have Michelle.
Hi, everyone. Michelle Clausen. I'm at Pfizer. I've been at Pfizer since 2001, pharmacist by training, part of our medical organization, what we call Worldwide Medical and Safety, that the Expanded Access Group reports up into. That is really just the operations and some of what my team does. We work with so many groups across the organization. So again, I think I'm representing a larger pharma company perspective and why we do this, why we think it's important. So nice to see some familiar faces. I look forward to the session today.
And Tom, last but not least.
Thanks, Claudia. Yeah, hi, everybody. My name's Tom Watson. I head up a company called biannual, and we run expanded access programs on behalf of pharmaceutical and biotech companies. I've also been a CUPA member pretty much since the start, and if you'd have seen Allison's post last week, CUPA's been going for a decade now, and I'm really proud actually to be here today because the people and the faces I can see in the audience, I don't think it's an exaggeration to say have been responsible for changing the lives of thousands of patients across the world since CUPA started. So real pleasure to be here today and looking forward to the discussion.
Fantastic. And to kick off our discussion, I'd like to actually combine two of the questions. Sorry, curveball. Talking about both why does expanded access need to be considered And I think it would be nice for us to combine with that the pros, and then we can get into the cons later. Rachel, would you like to kick us off?
Sure. So can you hear me okay? I believe it's on. So I think it's something that is not always going to be a conversation that's being had at a small pharmaceutical company. I think awareness is what you're fighting against. So the more we have these discussions at conference level, I think you're bringing back to small pharma this topic and the fact that it can be done effectively, and it can help your future launch of your product and access for many patients. So I think the pros of access are, we also use the pre-approval access term. The pros are that you're able to serve patients that are outside of a clinical trial. So if a patient is sick, but they don't have access because of their location, you may be able to reach them with a pre-approval access program. It also is going to help inform of the landscape when you do launch your product, and you will have access to those physicians. At our company, we recently had a publication that was done on a PAA, as we call it, program in Italy. And that was an amazing way to share with the larger community how these patients are being helped. The other part I think that's helpful for small pharma, you may encounter at some point in your lifespan the possibility that you will merge with another company. And that's a big curveball for the patients, for programs. If you have a fully developed pre-approval access program and are providing access successfully to patients, there's more interest, and hopefully it will help in many different conversations that are being had between, as you said, the pharmacovigilance groups, the patient advocacy groups, all of the regulatory groups that are part of that.
Thank you. So I want to talk about the large company
Sure.
perspective.
I think to add on, and I don't think the rationale is very different from company to company. It's the right thing to do. These are patients that don't have anything else. They're not eligible for clinical trials. These are generally severe, life-threatening conditions. When I came in to lead the team at Pfizer, it was a team that was already in place. We've been continuously improving and trying to really organize ourselves to be able to be more nimble and more efficient. But it's not going to go away, right? There are continually discussions, and although every therapeutic area and every program is for sure different, I can't say that every single program runs the same way, even in our organization. What doesn't change is that there is need, not only here in developed markets, but we see a lot in emerging markets where there is sometimes less available in countries, and even the regulatory path may be different from program to program. So many things that we try to ensure that we're looking at the bigger picture. And we do have a global SOP to try to do this as efficiently as possible across countries, but we do know there are generally some differences. At least in the US, you have to have a policy, in place and visible externally. So again, it's something that all companies have to really think about, more so earlier than later, because the last thing you probably want to do is start to get a bunch of requests that are coming in and you don't really know what to do or how to manage that. We're lucky enough that we have affiliates in different markets that we can lean on to really understand the local regulations, to have that relationship with the health authority. So we've been able to navigate some of the challenges. I think we also run into the portfolio size that we have at our organization. So as much as we would love to say yes, and generally to all the requests that are coming in, it is something that is done not only with my team, but with the asset team, with the safety team, to really understand what makes sense. And, thinking about this from a bigger holistic picture of, if we say yes to one, what the implications, down the road. So again, I think it's more, we take the approach of we have a team and a way that we're going to do this to try to make it as efficient as possible. And we try to bring in the right stakeholders across the organization to really help us with making the decision program by program.
So I guess this is a for and against panel, so it's important that we strike the right balance. And given the nature of our roles, both Michelle, Rachel, and then myself, I guess you'd be forgiven to think that we're very pro expanded access, which is indeed true. But both speakers so far have talked about the fact that it needs to be done well, and I think that I quickly flip to an against expanded access position if the company is unable to do that. I've seen these many programs work really successfully, and they all share some common ingredients. I think very early planning is important for companies for expanded access teams to work with asset teams to get it right. It needs full stakeholder engagement across the whole organization, and then external stakeholder engagement also. It takes a huge amount of resource and investment from the organizations, and clearly an exit strategy needs to be thought of very clearly up front also. Once you've done all that, then there needs to be clear, transparent communication plans for healthcare professionals, patients, etc. And that's a lot of work. And you know, I've seen really successful programs, and all those things have been taken into account, which is, from my point of view, for the benefit of patients, physicians, the company, and society as a whole. But if you can't do those things, then I think it quickly migrates to an against position from my point of view. So I'm trying to bring some balance to the panel, I guess, and I think it can be done, but you know, it needs to be taken very seriously. And even when you do all the things I've mentioned, on the second day that you launch a program, you know, a curveball, using your language, Claudia, is going to hit you. And having a plan and sticking to a plan are very different disciplines, I guess. So that's, I guess, my word of caution for the panel.
No, that's great. And I was reminded of, we advise companies on strategy on pre-approval drug access. And we always say that it is extremely important to have a strategy, even if you don't plan to provide it. But we have a client who did a program. We did a lot of testing of the policy. It went extremely well. They received a lot of requests. It led to an expansion in their label, and they became extremely secretive about it and refused to let me even share it with CUPA, which the reason is they are worried that it sets a precedent of expectation for their other programs that they may not be able to meet. So even when there is awareness, there is that concern of reputation. I wanted to talk a little bit about reputation, both from different sides of companies and from your observations on. Can you talk about how do you think in terms of both the risk and the threat to the reputation?
I think from a small pharma perspective, and I've belonged to 3 different small pharma companies where we didn't always have great buy-in. My first company, there wasn't a lot of support, awareness, or willingness to open up pre-approval access programs, and the latter 2 definitely did have that. The risk that I often hear is safety. What is the safety risk? We won't be able to collect adverse events. We won't know what's happening to the patients. It could jeopardize our approval in the US or any of the other regions that you are looking to commercialize in. And I think the other risk that I have seen consistently is when a regulatory pathway globally hasn't been fully fleshed out for small pharma, this can become a really slippery slope to open a program because you want to help and reach as many patients as possible. But in doing so, you jeopardize the development of that drug. If programs are opened in countries that the company hasn't committed to file regulatory filings, why have you opened that when they won't have an option after that program ends? Some companies may be able to provide access for life. Other companies won't have that ability. And I think awareness is linked into that risk because there are, as many of you probably know, countries that require lifetime access. And if you go into those countries not knowing this, that's a risk for the company as well. Because at the end of the day, drug development is extremely expensive. And if we're using all of our resources at the onset, we could deplete that and support for these kinds of programs.
Yeah, maybe if I can add on, because in addition to the things just mentioned, the clinical supply or commercial supply is always a priority. So even in our local or SOP, we can't jeopardize either the clinical supply availability or commercial supply. And as program by program, the manufacturing process, the storage of it, what is required for treatment, especially with some of these very niche products, can physicians, any physician, administer? What about adverse events, or do they need to have facilities to be able to treat potential adverse events for some of these very niche and new, especially oncology or rare disease types of therapies? So the risk is always part of that, is not only safety, risk, benefit, but the clinical or commercial supply. Can we get it? If we say we're going to do it, can we actually get it into the physicians, into these markets that we're looking for? The US, fortunately, has very robust and a well-defined path for expanded access. Other countries do not. And oftentimes we're waiting for the MOH approval. Even sometimes if it's as simple as an import permit, we may or may not be able to get it in time, for that patient's treatment. So I say one of the biggest challenges that we run into are in anti-infectives or antivirals, oftentimes where you have to start the treatment within a very short time frame. So if we say yes to one country that can do it, are we going to say no to another? So again, from a reputation perspective, I think these are all things that go into the decision making. And again, as much as we would like to start from a yes perspective, oftentimes we do have to say no because of these other circumstances around that, where from a company perspective, I think the social impacts and how social media, and I will probably talk about some of this in the ethics, but the escalation of awareness of expanded access or saying no is very much can happen very quickly. And that's an escalation process that we, pull in our corporate affairs teams and to make sure that they're aware of, when we're making decisions around some of these assets, the rationale why, so that we actually can help understand, from our company perspective of why or why not we might be doing something.
Yeah, I mean, reputational risk is probably the trickiest one of all, because there's a huge reputational risk for not providing access to a promising treatment that has passed some data bars, and the company is telling shareholders it's a great medicine, etc. So that in itself is a huge risk. But it does need to be an acceptance that a company is going to have to say no to a particular patient and family. And that's a very, very difficult thing to do, and a very difficult thing for the patient to accept. I have seen a sea change over the course of let's call it the last 10 years, in the way that companies are setting themselves up and organizing themselves and engaging with patient advocacy groups to get buy-in in the planning phase, that I think can minimize the damage of reputational risk. But you are always going to have a situation where desperately ill patient with their family and doctor supporting them, you may have to turn down access to, and that is, you're always wrong in that scenario, I'm afraid. So all you can lean on there is the planning, the consistency, the transparency, everything you've done to try to be fair as you possibly can.
Can you talk a little bit about transparency in terms of, the decision-making process or the reasons for denial? How much can or cannot share with the public about what the thinking is behind it? So
it depends. Again, every program is a little different. We do, even if we have a program and we're supporting it, from a Pfizer perspective, not every single case is always approved, because there is, even when we work with the teams, there's eligibility criteria that from an asset level perspective that might need to be adhered to from a safety perspective. So we'll communicate generally, because those requests are coming directly in from treating physicians. So we'll give them some type of rationale if we do say no. A majority of the things that we do, and if we have open programs, we do approve a majority of those. If we don't have an open program, that again, it depends on the program itself and in collaboration with the asset team onto how much information is shared. Generally, any patients or patient advocates or caregivers can ask questions of our group, and we try to be sensitive to the information. We do point them back to their physicians because they are, the ones that can help share the information back to them. But we do know that it's becoming more and more prevalent that patients, caregivers, patient advocates are going to want to understand the rationale. So something that we're always trying to look at and understand, is this the best way to respond? Is this something that we need to work with our, our very partnership with our corporate affairs group to really ensure the understanding as best as possible. So it's evolving though, I think, from a patient and caregiver perspective of how much detail that we're providing.
I think from a small pharma perspective, that internal stakeholder buy-in is extremely important to get at the onset, and then to communicate very transparently what your process is to the physicians when they're reaching out. If you have family members reaching out, we really, I think at the small pharma level, have a lot more access to patient information than a larger pharmaceutical company would. So making sure you're communicating what the timelines are, what the inclusion exclusion criteria is, that's all information that they need. And once that's understood and the groups, whether it's a patient advocacy group or the physician's office themselves, once they know that we've fully worked out a plan to see who we can provide access to, I think everyone kind of calms down. And we work a lot with patient advocacy groups in the beginning because they have access to information that a pharmaceutical company is not really considering, especially a small company. If you can publish any of your information on your process on your website so that when a patient group or a patient or a physician is accessing the website, they can see what to expect, I think that goes a long way.
I think it's just a positive message for me about how far we've come. I mean, it wasn't that long ago that even the idea that pharmaceutical companies, biotech companies would engage with patient populations about data, et cetera, it was a closed door. And we've come a long way in a relatively short period of time, in my opinion, particularly rare disease that's been a driving force of I guess those progressions. And I can see people in the audience that have dedicated a lot of work to this particular topic of transparency for patients and turning technical expanded access language, et cetera, into more patient-friendly digestible information that can be useful and can start to bring patients with us on the journey to, providing access to appropriate patients. So I feel very positive about how far we've come. A huge amount of work still to be done, of course, but yeah, feeling great about that.
I think the only other thing I'll add is that since we have larger programs and we have a request management portal that we manage the programs in, we're starting to look back and from a metric perspective, being able to share that with our internal teams to give them an idea of what a program could look like, because oftentimes they just have no idea like what the volume could be. And although every program is different, right? The therapeutic area, alternative treatments in the market. So there's going to be a lot of things that go into it. It does help, I have to say, to be able to share some of this is what one of our programs look like for this type of oncology asset. This is what the time frame looked like year over year as approval started happening in markets. This is what happened to your volume. So one of the things we're starting to look at is, could we publish that and make it more accessible to others, right, outside of our organization? It really just helps, I think, see maybe even where there could be some inequity of understanding of expanded access, or maybe where there's lack of regulations in countries, to understand, not only will you get requests in the US and developed markets, what about, African nations, what about Australia, right? So to be able to understand what that may look like is something I'm trying to push more to have, metrics on programs being available publicly as well. I know some companies do that, so it's not the unique idea. So the more that we can share that information, I think the better.
And I think the problem, sorry, Claudia, to interrupt, but I think the problem is, which I don't think we're necessarily going to change, is that it's the denial of access cases that are the high profile cases.
Yeah.
And, we deal with thousands of requests every year, and we are inundated with good news stories from healthcare professionals, patients and their families about the process, but that's not particularly newsworthy. So I think it's worth recognizing that behind the scenes there is a huge swell of positivity, but obviously, you know, the denial access cases are the ones that are the highest profile, of course, and for good reason.
Yes. There's no question that cost plays a significant role in these considerations. I assume even more so for small companies. We have begun to see clients budget for expanded access earlier on as something that they need to have through their clinical program. But with the markets being what they are and finances being what they are, as costs are being cut, that tends to fall into a nice to have category and be something that gets taken off the list very quickly. I was wondering if you could talk a little bit about cost and especially about the opportunity to charge for product and maybe recoup some of this costs in some countries, how attractive or unattractive that is and what considerations there might be.
I think for small pharma, it's really going to depend on the executive team's attitude toward access. And the earlier you can engage, as Tom had mentioned, the earlier you start, the better. And everybody in this room knows that. But bringing even your commercial colleagues within your organization to the table as early as possible to have them understand the life cycle of a PAA program, starting from access to whatever free of charge scheme you're going to offer in the interim after approval, waiting for reimbursement, and then moving on to that commercial drug product, because that's a pool of applicants a pool of patients that are already benefiting, that are big fans of this medication. So I think the cost is going to be something that is always going to be there, and the cost could rise if logistical challenges present, if, as you mentioned, drug supply becomes a problem. Of course, for small pharma as well, clinical drug supply can't be jeopardized for these other programs. But what we didn't talk about is the possibility of a drug supply having some kind of excursion or defect that means the entire batch needs to be discarded, which we have encountered many times. So that is, again, another cost that you didn't budget for. And there's a lot of factors that are well outside of your control. So the earlier you bring in those stakeholders, have them understand that life cycle, how is this all going to play out? Of course, we know we're doing this because we want to allow patients to have access who otherwise wouldn't be able to. But we have to make sure that everyone in the company understands what their role in that is.
So we have generally tried to take the approach we're doing it free of charge, unless there's country regulations or local requirements for a different approach for that. However, as you mentioned, it's not free to the company, right? In the past, we have taken the approach where if our clinical trial supply can accommodate it and they absorb that and just kind of pack and label some for expanded access, depending on what they feel the predicted volume may be, they'll try to do that. That, again, has been very different from program to program because of the unique nature of some of these therapeutics. So again, what we're finding is that we're starting to try to plan for that budget earlier. But again, who's paying for that? Is it coming from my team, which doesn't have a budget? We're just there to help resource it. Does it come from the asset team? Does it come from the countries? Some countries have a lot of import and VAT and some of those things. So I have to say, even with a larger company, we do struggle with who's paying, who's going to really accommodate the cost of the supply and all of the things that go along with it, because it's just not the supply, it's the, moving the request along internally and the resources that are needed. So we're in dialogue constantly with our clinical supply team, our commercial supply team, to really understand how best that we can plan for it and maybe be more proactive, in the very onset. So again, that's why I think we're trying to use metrics a little more to be able to help asset teams predict maybe what volume they could see. And they often go to the countries to say, if we were to open an expanded access program, assuming that our regulatory plan is to file in that country, what is the potential volume? Those numbers are best guesses, at best, because until you open a program, you really don't know what's going to come in, as these are usually unsolicited requests. So I think that is a challenge that, again, no matter the size of the organization, is the cost component to it. Is something that is but program by program. I hate to say that all the time, but what we have really found is that each program is very, very different in the things that come up during it. What are the types of requests that are coming in? Even once we launch a program, are the eligibility criteria issues? Like, are there, are there understanding? Are there things that we just didn't know because it's a brand new therapeutic area? So, but we learn from every single one of them. So again, we're trying to bring that back to our teams internally as well.
And I think if I could add just one more thing for small pharma, just a cautionary note. When you start thinking about free of charge programs, those sometimes would be run through the commercial group. And if you hadn't invited those stakeholders to the table very early on for these development conversations, they could go rogue and open these programs that you actually don't learn about until they're open. And that causes reputational damage in the event that some of your access patients aren't able to get access, but patients in their same country or city are getting access through a free for charge program. So I think that alignment internally is vital to make sure that you're providing access in the best way. And if you hadn't invited those commercial colleagues to this conversation, if they were very much in a silo, you wouldn't be aware. And that causes a lot of complications in my experience.
Yeah, totally agree. I know we're running out of time, but the tension between medical affairs, expanded access teams, and then commercial needs to be thought of very early on, and actually often an afterthought. I agree, and we advocate free of charge access where possible. And then we're going to talk later about real world data, I believe, and the benefits of that for the pharmaceutical company, might go some way to offset some of the costs of these types of programs. I know we're out of time. So
yes, thank you so much. Please join me in thanking the panel. And we'll be back for Q&A together with the ethics panel. It's coming next. So I welcome Ken.
All right. That was a great panel. Thank you, all panelists. Well, good morning. As the panel's coming up, my name's Ken Moch. I am a biotech serial entrepreneur. For those of you with long memories, and Tom alluded to earlier expanded access situations, I was the CEO of Chimerix during the Josh Hardy social media event, which strangely enough is almost 10 years ago right now. And I've spent some time, in addition to being a serial entrepreneur, advising both small and large biotech companies. Is Jen here? Jen's here. Sorry, you were on that side as I turned. So we're going to focus on, as noted, the ethical case for and against expanded access, and bring some of the discussions from the business side of the equation to the ethics side. And kind of without further ado, perhaps Lisa and Jen, starting with Lisa, you can introduce yourselves and kind of give some of your perspectives on this. And one of the questions that I'll ask, we all want expanded access to be utilized as appropriately and often as possible. The third rail is the case against, and I think that we need to not paint that, but rather ask the questions of the considerations, both business and ethical, as we think through this this day. So let's start with Lisa and maybe talk about some of those issues, both positive and well, for and against is a better set of words for the ethics side.
Thank you, Ken. Should I introduce myself?
Yeah, please.
Or do you want to introduce yourself first? Okay, great. Hi.
Jen will get to it.
I'm Lisa Kearns. I'm a senior research associate at the Division of Medical Ethics, and I have been one of the longest members of CUPA as well, along with Tom there and Jen. And it's really been one of the most rewarding things in my bioethics career. Early on, it was when it was just getting off the ground. I joined right when Josh Hardy was in the news and was a big ethical consideration, and that's kind of how it started with Ken Moch. Reaching out to Art and moving on from there about ethical issues in equity to access, equity in information, social media savviness playing a big role in access to investigational drugs. Also, right at the beginning of my tenure, the Right to Try movement started, and I think it was Allison who said, you take it, you look at all these state laws and see what's going on in them. And so I did. So I also know a lot about right to try. I've spent a lot of my time at CUPA working with other people, trying to argue against it because of lack of patient oversight and patient protections and a bunch of other things, which I'm not going to go into right now. So it's interesting that I spent so much time arguing against right to try and for FDA expanded access. And now I will come up with some ethical reasons against it. I go, okay. So before I get to those ethical reasons, I just want to say that the first panel was excellent, unsurprising, but it really brought home, and you might have noticed this from all the CUPA members nodding along vigorously, it really brought home the fact that in this country with our economic system, our healthcare system, our drug development system, business ethics, the ethics case for and against expanded access in the business context are intricately entwined with the ethics cases. And that's because of the goal of drug development, which is to get safe and effective drugs on the market for the most people to use. That's a public health imperative, and that's a moral imperative. And so our CUPA is multi-stakeholder. We have industry, we have regulatory people, we have healthcare providers, we have patients, and we have straightforward ethicists. And I think the one thing we've learned there that in this country is that you just can't really separate all of those out. I think, yeah, the small pharma, I'm sorry, I forgot your name, but the small pharma case is really interesting because I don't think it's the case that everybody wants to have expanded access every single time because there are just often good reasons why not. There are really good business reasons, and those include resources, money, staffing, availability of the drug. And those are ethical reasons too, because if you don't listen to those, if you go against those, then you're going to halt this drug development process, and then we won't get drugs on for more people to use. So I wanted to just say that even though on the agenda, these look like two really distinct panels, they're not. So that said, there are some ethicsy reasons to consider not providing expanded access. And the two that I'm going to mention now, they're based on two facts about expanded access. One is that by definition, investigational drugs have not been proven to be safe nor effective. As the drugs move through the clinical trial development phases, you might get more confidence in their safety and their efficacy, but they have not been approved by a regulatory agency as such. And we also know that drugs that have been proved to be safe and effective enough to be marketed have been pulled from the market. So it's just a fact that these are still unproven, experimental, investigational, whatever you want to call them. So that's one thing. And also by definition, the patients who are eligible for expanded access are very sick people, unfortunately. They have no alternative treatment options. That means everything they tried either didn't work or it worked and stopped working. They may have comorbidities. They may have weakened immune systems. If we're talking about oncology agents, they may have metastases. And a lot of these reasons are why they are ineligible for clinical trials, although there are other reasons why they may not be able to participate. So those are two foundational truths about expanded access. And I'll just say, so even if you're going in late phase 3 of drug development and you've got a lot of evidence for safety and efficacy, we also don't know how these particular drugs will work in these particular patients because of the lack of including these patients in clinical trials. So that's the foundation for my kind of two big ethics reasons for not providing expanded access, or considerations if one were thinking about expanded access. So all of that said, that makes for a patient and for a physician or for a family weighing risks and benefits of whether to try an experimental drug very difficult to assess. Again, these are unproven drugs. They're especially unproven for these types of patients in these specific conditions. And so what I'm getting to here is, as you probably all know, is that for expanded access, the soundness of the informed consent process is always something that ethics has to keep a really close eye on. So we don't have a lot of information always to assess risks and benefits. We don't have a lot, if we have information for one group of patients, we may not have it for another group of patients. That leads to another consideration for informed consent. And there's this, and again, it's this idea of the health and the physical status of the patients seeking it. And that's something called a therapeutic optimism or therapeutic misperception. So you have patients who have exhausted all treatment options, and this agent or medicine or device or whatever they're seeking may be their last chance. And the fact that one would consider that a last chance sort of, you might say, it exerts an undue influence on the decision-making process. This has to work. It's not working isn't really an option in my life or for my child. So that is another thing that really influences a sound informed consent process. And then finally, on the informed consent, I'll just say that one thing that we hammer home in CUPA and in informed consent, and especially when we start talking about N of one, N of a few gene therapies, is that expanded access is treatment and drug development is research. And if you're a patient or you're the parent of a sick child and you hear, okay, this is expanded access is treatment, you're think, okay, my child or myself we're going to receive treatment, we're going to be treated. And that also leads to this kind of therapeutic misconception. So those are some reasons why the informed consent process is not always going to be very sound, or at least must be really closely monitored by physicians and patients. And it's a good reason why we have sort of the oversight layers in place. And then just for my closing remark here, this kind of reflects back on something that's been said many times. And I just take issue with the idea that expanded access is a good all the time and something that everybody wants in every single case. And the reason being is that, I've been talking about this since 2014. And I've heard many times people have asked whether it's ever ethical to give an experimental drug to somebody outside of a clinical trial, A, and is it ever ethical to give an experimental drug to somebody outside of a clinical trial who is very, very sick and has no treatment options and may not be able to tolerate it and may not be able to adequately weigh risks and benefits. So those are my two main points about the ethics considerations against providing access, the difficulty with getting a robust informed consent process, and just the question of whether it's an ethical thing to do overall in all cases. Thanks.
Jen?
Thanks, Lisa, for those really provocative thoughts. Before I dive into what I was going to say, I would love to take a few minutes just to respond candidly to what
Do you want to give your background
your
first?
remarks. Sure. My name is Jennifer Miller. I'm co-director of the program for biomedical ethics at Yale, an associate professor in internal medicine, and my secondary appointment is in biomedical informatics and data science. And I direct a project called the Good Pharma Scorecard at Yale School of Medicine. And I serve on several ethics advisory committees for pharmaceutical companies, and a lot of the cases that we get have to do with expanded access and compassionate use requests. So just commenting on Lisa's really thoughtful opening remarks, I wanted to sort of offer some additional thoughts, like building upon two things that you said. One is on how experimental are the experimental agents that patients are requesting through expanded access programs. So I just want to add a little empirical data. I didn't know we were going to talk about this, but let's do it. My team did 2 studies looking at over 400 expanded access and compassionate use programs registered in clinicaltrials.gov from, the earliest dates all the way through 2017. So this data is a little bit stale, but the trends could have changed between 2017 and now. But what we found, of those 400 programs, 76% of the drugs that were provided through those registered expanded access and compassionate use programs eventually received FDA approval. This suggests that drugs at least provided through registered expanded access programs up until that date are more times than not eventually deemed safe and effective by the FDA. Although we cannot entirely rule out safety and efficacy questions, as nearly 25% of the expanded access drugs that were provided have not yet received FDA approval. And then we also wanted to look at the timing of when those drugs are provided to patients. And generally speaking, 70% of expanded access programs are initiated within the 6 months preceding the filing of an NDA or a BLA, so 6 months before or 6 months after the filing. So it's within the last 14%-ish of the clinical development program for a product. Just thought that might shed some light on where we are.
That's data through 2017.
1901, no.
Yeah, sorry, wrong decade. What the hell? It's 2024 as
Yeah,
well.
what year are we
Right?
in? It's through 2017.
Right, so
Yes.
7 years.
And we know requests are escalating,
Right.
so it's entirely possible that those trends have shifted somewhat, but at least those held up until technically July 5th of 2016. And then, so just to contextualize like where are we in the development of our phases and safety and efficacy information. And then the other piece that you really interestingly brought up is this idea of undue inducement, because it's the last hope. Hope I'm not paraphrasing incorrectly. And Zeke Emanuel wrote this really interesting piece. This is from a long time ago.
Dark ages.
Yeah. And he said that he raised this question of whether undue inducement, at least in the clinical trial space, was nonsense on stilts. That was the title of the article. And his main argument being that because an IRB, an institutional review board, an ethics committee reviews the protocol, that it's judged to have a reasonable risk-benefit ratio for patients to participate, and therefore isn't unreasonable for.
That was in clinical trials?
I don't remember the exact
Or
location.
expanded access?
No, this is for clinical trials.
Okay,
But
that's.
So putting right to
Sure.
side, right to try aside, because that doesn't generally go through an IRB approval. An expanded access program does undergo IRB review. And I just wonder, I'm not arguing this, whether the same arguments that Zeke Emanuel uses for this, for clinical trial, undue inducements for clinical trial participation being undue inducements, if some of that might apply. And I have not analyzed this, but I just raised this for further discussion.
I would just say that, yes, of course, there's IRB oversight of the expanded access process, but the tolerance for risk goes up as the prognosis worsens. So that does not mean that the safety, that the IRB is okaying it in a specific case for a specific patient, not for the efficacy or the safety of a drug overall, but it is very interesting.
Yeah, that the IRB would have deemed it reasonable risk to benefit ratio. Okay, so that wasn't what I was planning to say. I just wanted to respond to a really
By the way, I'm going to come back to the
valuable
question
comments.
of.
You can just forget my comments.
No, we want your comments, but come back to, I think the idea of looking at approvals. I know where that came from, I think.
You may have been a co-author on that paper.
I was a
Yeah, on one of
co-author.
them.
I think it started with my question, but then the question becomes, we should update that because the
Yeah.
question for later for the business panel as well is, we now see expanded access starting in phase 1. People doing that as their first foray into human clinical testing. And that'll be for the group, but should that be the way we're going? Because I think the paper that is 2017, it's why I clarified that, is outdated in current practice
Right.
for expanded access.
Right, we don't know if.
So I think
we
the
don't know.
data of plus or minus 6 months from phase 3 and 75% approval stood. but doesn't stand. Okay, that's
6
enough for
months
that. Let's,
from
And
NDA
forget it with
filing.
gene therapy and,
Sorry?
N of
6
one.
months from NDA filing.
right, plus or minus 6 months, sorry,
Yeah,
from NDA
yeah,
filing, which
yeah.
means you have phase 3 data in hand.
Maybe, yeah, not oncology, but. some
Yeah. Anyway,
conditions.
keep
Yeah,
going.
Okay. Point is, we need to update the study. I completely agree. The trends may have changed, but we don't know. So I wanted to talk a little bit about barriers to accessing experimental medicines via the expanded access pathway when it makes sense, when there's enough supply, when the company has the operations to provide it, when the risk-benefit ratio is makes sense for the patient. And then I wanted to turn around and talk about some of the strategies we might be able to implement to reduce some of those barriers that are driving disparities in access to the expanded access pathway. So we all know the gatekeepers that are involved. And today I'll just focus on 3: clinicians, the IRB, and the product manufacturer or sponsor. So let's begin with the clinician level. As we know, when we look at the clinical trial space, clinicians who are located in cities, on the coasts, affiliated with large academic medical centers, and exposure to the clinical research ecosystem are generally better positioned to navigate the expanded access pathway. These clinicians, studies have shown, are consistently more likely to refer at least adult patients to clinical trials at higher rates than other clinicians, such as those affiliated with community health systems. Why is this? Studies have shown that these clinicians tend to see flyers hanging up in their centers, advertising experimental medicines, or at least informing about them, and open clinical trial opportunities. They tend to be more included in research meetings that are discussing experimental therapies. Many have access to internal databases about active clinical trials at their center. And some have access to an active participant screening process that screens all patients for eligibility for active trials. So the challenge is that many patients who are pursuing the expanded access pathway are not receiving care in the major cities, in large academic medical centers, and on the coasts. You can just take one example: high-risk hematologic malignancies. Most patients there are treated in community oncology practices near their residencies for a variety of reasons. So the access to your clinician, the clinician that you have access to, can determine how easy it will be for you to know about and pursue an expanded access pathway.
And so just so I understand, the ethical underpinning of that is just fairness of location?
Yeah, so
What's
for-
the ethical for or against in there?
Thank you. Yeah, let's go to the punchline.
Only because we're gonna hit time soon, so I'm just pushing.
Yeah, so we don't want to just provide expanded access to some patients who could reasonably benefit, and it makes sense to provide it to. We want to provide it to all fairly, for fair opportunity. And what I'm saying is there are barriers to providing a fair opportunity for all patients who reasonably would benefit from an expanded access, pursuing an expanded access pathway,
And
including.
that falls to,
That's an ethical consideration under the principle of justice, right? You want everyone to have everyone who reasonably should get expanded access to be able to have a fair opportunity to pursue it.
okay, keep going. I'm
Yeah,
sorry. I'm over moderating you.
No, I love it. Keep going, keeping it more interesting rather than me just droning on. So, and then 2 other is the product manufacturer. So there's an easy way for sponsors and product manufacturers to improve awareness and access to investigational medical products. And it was talked a little bit about already. The 21st Century Cures Act, passed in 2016, requires many, not all, drug companies to publish their expanded access policies to increase awareness among clinicians and patients about how to access investigational medical products outside of trials. We all know what they require. The Act suggests that these public policies should explain how and who to contact at the company with an expanded access request, the criteria the company will use to adjudicate on requests, and the timeline the company will follow and evaluating and responding to requests, among other types of information. Unfortunately, uptake or compliance with this Act is low. Another study that our team led, not outdated,
I'm sorry?
that's not so outdated,
Good.
found that 23% of applicable reviewed companies in the oncology space, and we looked at 423 companies, only 23% had a publicly available expanded access policy as required. Those that did have a policy, that 23%, 1 in 3 companies, only 1 in 3 had all of the informational elements described by the Cures Act as important for patients and clinicians to know. 1 in 5 failed to provide contact information at the company. 2 in 5 failed to indicate the criteria the company will use to evaluate expanded access requests. And unsurprisingly, smaller companies and newer companies were less likely to have public expanded access policies. And as we know, at least 50% of the novel drugs and biologics that the FDA has approved in the last decade are sponsored by non-large companies. So in terms of information and awareness and being able to navigate the expanded access pathway, it's really important that we get companies to.
Hey, Jen, you made a comment twice. I just have to ask you about. You said that it should be published so there's awareness of and people know about. Is that the reason for this, or that people, if they're interested, can find where to go? There's a difference, because advertising in experimental medicine is not part of the law. In fact, it's against the law. Doing it for clinical trial purposes is okay, but to say we have an expanded access program, please sign up for our great experimental medicine is not.
Right.
So I'm wondering how your finding works within the context of awareness versus responding to requests. Did you look at that level? I don't know if you talked to
no,
any
I
of the
think
companies.
you're absolutely right. So having a public expanded access policy would be helpful, but not sufficient, right? In getting the patient ultimately to the experimental therapy that they may benefit from or not.
Although, if just a quick interruption with apologies, is that the lack of compliance with 21st century cures, I think, is a big deal from the patient perspective, because if you just think about somebody calling and getting a phone tree, or somebody waiting for a call back with a sick child or a sick person, I mean, just that bare nuts and bolts things of like, could I just get an answer, a yes or no answer to whether you do this, or can I move along? I think that's a huge ethics thing. It's great you mentioned that 21st century.
And I'll
cures.
just add, because it needs to be added, you should publish if you're in phase 2 or above your expanded access policy, which includes the right to say we do not want to make our experimental medicine available under expanded access at this time. And that's neither ethical nor, well, it's ethical or business, but it's the right of the company to say that. And I think that Michelle, not to put you on the spot, but this morning you said expanded access is, quote, the right thing to do, unquote. It may not always be, and that's actually the purpose of these 2 days, to discuss when it is and when it isn't. Back to you two.
And then just wrapping up, these barriers that I'm talking about are addressable. I don't think we're gonna have time to talk about how we can address them, but they don't need to be as profound as they are. And there are so many bright spots of clinicians, companies, patient navigators going out there to try and reduce barriers. And then I'll just wrap up with, there are also financial barriers to participating in expanded access pathways. While most drugs are provided free of charge through expanded access programs, this isn't always the case. And as we know, companies can be authorized by the FDA to charge a patient direct and indirect costs of making a drug available. Insurance companies, most insurance companies will not cover access to an investigational drug. So even if a drug is free, the patient or the health system may need to absorb other expanded access related charges.
That's another study for you, by the way. I think that, I think just to comment on that, I don't think I know of any biotech company that's charged for experimental medicine. There may be some, that's something to look at, but I also think that if the company's made it available, how often do the insurance companies not allow the provision of that experimental medicine because of cost considerations? Would be
Or the
interesting.
formulary at the health system because of cost considerations.
Right, so that would be one to look
Yeah,
at, but
I
I don't
agree.
think we have a definitive answer. We have a theory, but not an answer to that yet.
Only anecdotal evidence. And then I think so the point of describing barriers isn't to be depressed about them. It is hopeful by nature, by the fact that you complain that something should be better, it suggests that it can be better. And there are a lot of lessons that we can learn from how companies and other stakeholders have made efforts to diversify clinical trial participation, improve fair opportunities to participate in clinical research. And I think a lot of those strategies are translatable to the EAP space. Just to name a few. Well, I won't because I think we're out of time, but stay tuned or see me in the hallway if you want to learn more.
Right. Well, let's just do that quickly and start this. Is it ethical to provide expanded access as a phase 1 medicine? You know, we look at the pros and cons. There's one, we got 2 minutes and 14 seconds, and then we're going to bring up the other folks to go on with this, but
I can do it in 15
go
seconds.
forth.
It depends on the patient. It depends on the drug. It depends on the circumstances. It's going to be different. You can't have this. This is your word. This
No simple monolithic solution.
Monolithic solution, and that is true.
Yeah. All right, that solves that problem. Next.
Anything else?
Well, sure. The other one is the other side is the ethics of not collecting data on the results of expanded access programs. It's not required. The FDA, you know, physicians theoretically, if it's a physician-sponsored expanded access request, are supposed to provide data at the end of that. Generally, they do not. I know of at least one company that was required by the FDA, because it was mine, required by the FDA to go out and find out what was really happening. But how often does that not happen or happen that you know? Because if you throw an experimental medicine out into an uncontrolled situation, because it's fundamentally uncontrolled, and you don't collect the data at the end, do you know what happens when you're asked for the next patient? So there's an ethical dilemma that I think, you know, is pretty hot still to this day. What do you think?
So legal requirements and ethical obligations are not the same thing, right?
know.
I agree. Companies are not legally required to report results of expanded access pathways and say clinicaltrials.gov or something like that. And when we reviewed those 400 programs, I think only 2% of programs had some kind of results, summary results in clinicaltrials.gov in connection with the EAP. But absolutely, I think there's increasing results gathering and reporting. We've seen an increase in expanded access program data in NDAs reviewed by the FDA. And I think it doesn't hurt.
Yeah. So I'll make the comment that a biotech company is a research and development pipeline unencumbered by revenue. So if you have to spend more money on collecting data or anything else, it makes it less likely you'll be able to afford to do your EA program, with which,
Yeah, it's not just the
like the
company
way I
that
did
will
that,
incur the cost.
with which
though,
we are
right?
out of time on this panel. Please join us for our joint Q&A. Audience, you, like the way I did that, Jen? That was a smooth transition. You are required to ask questions of us. Sorry?
Protecting my panel from you.
Why? I already asked my 2 questions, but from a business, I'd like to go back to while we're waiting, because nobody has yet. Oh, we do have one. Kind sir over on my left.
Oh, now I'm on. Thanks very much. This was a great panel. My name is Toss Cochran. I am a medical ethicist. I'm at the Harvard Medical School Fellowship for Bioethics as a co-director. And for the last few years, I was at Biogen working on expanded access, among other things. One of the many topics that I think we still need to cover over these 2 days is the ways in which EAP can potentially compete with randomized controlled trials when they're conducted simultaneously. In the ALS space, it was proposed to me that we ought to be doing EAPs alongside our phase 3 randomized controlled trials. And I'd never heard anybody really confront whether that would distort enrollment in the trial, especially in a disease where the eligibility criteria are somewhat subjective or more than somewhat subjective. The solution that was proposed to me has potential problems. The solution that was proposed to me was, well, you make your eligibility criteria and you have to screen for the trial at the site. And if you screen fail, then you go into the EAP. It's as simple as that. I can imagine a couple of problems with that. One is, the biggest one is that it will create a motivation, right, to screen fail for the trial, which is possible in the ALS space. And then the other is that if you pass, if you screen to get into the trial, now you must participate and you won't be permitted to participate in the EAP. You have to be in the trial. You can't be in the EAP. And that seems to run afoul of the rule that your clinical care can't be contingent on trial participation, right? We can't force you to be in a trial and then make your future care contingent on remaining in the trial. And so I don't see a clear solution to that. And maybe the panelists could talk a little bit about the competition between RCTs and EAP.
Can I?
Yeah, go.
Very quickly,
Yeah.
I don't want to hog this. I will just say that if I'm understanding this right, if the patient can get in a trial, but doesn't want to, or somehow, rigs the system so as to go into an EAP, then that's really violating one of the eligibility requirements, which is ineligible for a clinical trial. And we know that that patient is eligible for a clinical trial. So just very quick, there are reasons why patients can't physically get to a trial. They may be eligible, but they can't get there. They can't get the time off, all those things. But if you stipulate eligibility of a patient, then that makes that person ineligible for expanded access. For your question about, you're talking about parallel track, like EAP, I would refer you during our networking session to Richard Klein, who is here somewhere. Okay, he's right there, who was instrumental or heavily involved in the parallel track expanded access program that was established during the AIDS epidemic, which is what sort of brought expanded access in the modern realm. So I'll stop that on hog.
The legend that is Richard Klein.
Yeah.
Didn't see Richard Klein.
No, apologies.
Maybe
Nice
I'll
to see
just
you,
add
Richard.
to, I think, the communication and understanding the development plan for any asset is also critical for anybody that's doing expanded access. So not only are we thinking about like the clinical trials, but they're also looking at pre-approval programs in other countries. Some of them have very local programs. UK has EAM scheme, France has their own. So I think for my team, understanding what it is, because if we get requests that are coming in, we'll try to understand, are they eligible for clinical trial? Because obviously that's the preference. If they can participate in a clinical trial, that's really the preference. Oftentimes they have a sponsored EA, like a company sponsored EA protocol. So again, depending on the program again, understanding the strategy overall and making sure that that communication is happening, I think for us has worked pretty well.
The tricky part is that in ALS, it's easy to game the eligibility criteria, both for
Yeah.
physicians and patients. And so for somebody with some experience in the space, you might want to argue with me.
Yeah. Gwen?
Toss, if you could hold that for me. And yes, we should talk about that, Toss, because so let me back up. My name is Gwen Peterson. I have ALS. I was diagnosed in 2018 at 32 years old. And it's Toss really quick. We can chat. I wish there was more gaming in ALS, but unfortunately, the majority of us simply do not qualify for trials. And if we do, we are flying all over the country. We are putting our caregivers out to participate. So we can chat about that in a bit. I wrote down a note for Jennifer. Jennifer mentioned that in a perfect world that doctors refer patients to trials and expanded access protocols. Unfortunately, I'm only speaking for ALS, but I wish we were referred more, right? It would make this so much more seamless. The reality is, a lot of times, I'll speak for myself, patients do the legwork. We're bringing the information to our physicians. I also wish Jennifer mentioned, and I'll have to pick your brain, an active screening process. Another thing is when patients bring information to our doctors, in my case, my neurologist, I have had a neurologist say to me before about an EAP, why would you want to participate in that? There's simply not enough evidence. Why? And we also heard staffing issues. That's a huge deal, staffing limitations. So I'll stop there.
Over here, or would anybody else on the panel want to answer, provide any other comments?
Just a comment, I think the example of the ALS example recently for tofersen was well publicized in relation to a parallel early access program, as we talked about reputation, et cetera, earlier. And I think some of the things you've mentioned about slight change eligibility criteria, et cetera, are really important. We've had good examples where we have had parallel early access, expanded access programs alongside clinical trials, but it does take a collaborative effort, and there is a partnership between healthcare professionals, patients, the company, and we've tried to engage healthcare professionals in the reasoning why we have to prioritize clinical trials from a regulatory and ethical standpoint. And it's been successful to a point, but I do understand if people want to game the system or align about someone's eligibility to a clinical trial, et cetera, it's very difficult for companies to be able to monitor that. So I think it is possible. I think we should strive for parallel expanded access programs, because I think that hits the heart of what expanded access is all about, to try to broaden the access across groups. But I do understand the challenges that were cited in the original question.
Sounds good. Question?
Hi, everyone. I'm reading questions from the Zoom chat. So the question I'm asking now is, can you speak more to the risk of safety events to the label? FDA claims that EAP does not commonly impact a drug's label or approval, but it seems to remain a constant worry within companies. And this person asks if this is a rational fear.
So this is where we need the legend Richard Klein to comment on that from an FDA standpoint, because I know that you've been doing it. Yeah, please do, Richard.
So that was a very common charge or statement about FDA looking at EAP.
Richard, do you want to introduce yourself?
Yeah, Richard Klein. I'm currently with GE2P2, but worked at FDA for almost my entire career. And was involved in writing the expanded access regulations. And so one point is that from my position at FDA, I work very closely with the review divisions. The people there are very smart. And, you know, as was pointed out, the people, Lisa pointed out that people who get into expanded access are usually very advanced patients. I think it was you who had pointed that out. They have a lot of problems. They may have comorbidities. The people at FDA who look at these adverse event reactions are very aware of that. And so they do extensive analysis of what are the variables about the adverse event that has occurred. So CDER, the Center for Drugs, had done a study going back 10 years looking at, well, how many adverse events were reported that caused the clinical hold, didn't stop the ultimate development of the product, but put the process on hold. I was involved in one of those, and I think if the agency had not put a clinical hold on that, it would have been open to very round and well-deserved criticism, because there was a sudden unexpected death. And as it turned out, the information submitted by the physician was out of date, and the patient was much further advanced. But I think, you know, people are put up against tremendous challenges in trying to figure that out, and they're very careful about how they do that analysis. So over the 10 years, there were only 2 cases that were found where there was a clinical hold imposed. And so I think, you know, what's important to keep in mind is that the people at FDA are very aware of the fact that these are people who are on the edge, who are very likely to have adverse events or to die as a result of their disease or comorbidities. And they're very aware that it may not be, and it is usually not, the experimental drug that has caused the adverse event.
So due to the work that Richard and others have done, I think to dispel, if we can call it a myth, over the years, I think companies are more willing to provide access, which is a function of decreasing levels of anxiety. But I think to sit here and say that research and development teams are not terrified of safety events derailing clinical development would be a mistake. So it'd be interesting to hear from the pharmaceutical and industry folk whether that still exists.
I think from a small company perspective, it's our responsibility as the champion for EAPs to inform the company that there's little risk and provide the statistics on this, because there is not an awareness and there is a lot of fear. So we have to continually educate our internal stakeholders on what it is that we're going to face and what other companies are doing.
I'm very similar. I mean, it depends on our internal teams on how familiar they are with expanded access, because if they've done programs, they're usually familiar. We report adverse events like we do, it's a requirement, if any of the requests that we approve, so the physicians have to agree. It's probably more real world. It's not being monitored as our clinical trials are. But again, I think that's why, as much as we're trying to do is leverage the prior programs that we've had to be, again, bring that awareness to our internal teams. I can, or my team can really talk to it if it does come up in different conversations. That's not the reason why we're not, we say no to a program, is that potential for how the FDA might interpret it, or any other health authority as well. But as part of the process, I mean, the safety risk benefit is going to be critical. As we had mentioned, these are investigational products. We don't know the full portfolio, especially before it's been approved anywhere in the world. So it's definitely something that, again, the teams really have to consider all the things that are happening around that asset, because every program is a little bit different on what the nuance is and things that they're considering, and making sure that everybody's aware of what expanded access is and what it's not. It is treatment, it's not research. So again, that is a very large conversation we've had internally, as far as, I think everyone's trying to figure out how to use the data. Does it make sense to use the data? And then, being really clear with health authorities too. That's been our internal discussion around this. It's like, if you want to use it for something other than internal understanding of the program overall, have that conversation with the FDA, have that conversation with the health authority, so that it's really clear on, what we're going to be doing with expanded access, and how we may or may not use that data moving forward.
I might add, there's probably another paper there because, and Richard, I don't know if you considered the Chimerix days, but we were on partial clinical hold because of an expanded access protocol, because the physicians decided, some group of physicians decided, well, if X is good, we're going to double the dose and cause side effects. So I do think that there's an interesting question there, which we don't talk about. Yeah, I can see your smile.
If something's good, more is better.
More must be better. And, cause a side effect to put us on partial clinical hold, as the FDA described it, which was you can't enroll more patients, but for 6 months, and almost killed the company. So I think it is a fear, but maybe it's gone away now with more awareness. I don't know.
Question right here, Rafael.
Hi, Rafael Escandon from the Seattle area. Thank you to both of you as moderators and to the panelists. I have a comment and then just a couple of questions. Just to add, it was actually inspired by some of Jennifer and her team's work. Kara Hunt and I last year at the American Society of Cell and Gene Therapy presented a poster about compliance with Mendelian gene therapy programs and their compliance with the 21st Century Cures Act. So if anyone wants a copy or a PDF of that poster, we're happy to provide it.
Wait, what
it
did
was
you
very,
find? Yeah.
it was very consistent with Jennifer's findings, her team's findings. So spoiler there. The second comment I want to make is that, having worked in clinical R&D, no longer, but for a long time, my experience in expanded access and the myths is very consistent with what the panelists have said. So I think that's also important. Hopefully it just continues to get better and better. And then finally, my question regarding is more to the current pharma and biotech panelists. With gene therapies and with highly targeted therapies, there are many things that would exclude patients outright whether they've been exposed to the AAV vector, for example, and the list is very long. But a lot of that requires education of advocacy groups and patients themselves. So a request may come in or a pre-request may come in. Just curious about how you handle those that the unfortunate situations where patients are really just ineligible outright.
Well, I think some of these newer areas, gene therapy and some of these rare diseases, they're just very unique assets now, very different than some of the prior programs that we've had for expanded access or some of our traditional oncology medications. So we've just taken a different approach to those where we're going to evaluate those separately. We have a separate policy for gene therapy now, which we say, you know, right now, this is our policy. We are committed to evaluating that as information changes or the nature of our programs change. So I think it's really what you'd said is making sure that patient advocacy groups are also helping to communicate that these are just different programs, are different than our traditional, you know, molecules for in that there's so much risk or unknowns to it that saying yes again to one area where we're trying to be equitable at the same time. And so I think these are just very different and unique for us, where we're taking them a different approach slightly to these and evaluating them on a basically the asset level, you know, and understanding what that changing environment looks like and really committing to reevaluating that policy as the environment and our development changes.
We have about 2.5 minutes, so we got 2 more questions with quick answers, please.
Hi, I'm Donna Cowan. I work at a very small biotech in the Boston area in the area of rare and ultra rare diseases. And I have a couple comments, questions that kind of go across all the things that you have very nicely been speaking about. One of them is the inequity of access to expanded access. So our lead candidate right now is for an ultra rare disease called Barth syndrome that most people don't even know about. There's about 130 patients identified in the US with this disease. And the patient advocacy groups are wonderful at reaching out and trying to get more information. And the bottleneck that those patients quite frequently see is at the physicians. They walk in with information, the physicians don't know enough about either Barth syndrome or expanded access, and it stops there. And then weeks or months later, maybe when it's even too late, we get the call from the patient advocacy group wanting to know what we can do, how we can help. So that's just a question about inequity in general in clinical trials and expanded access. Not really a question, but a statement. And then the other one is, there's been a lot of discussion about risk-benefit profiles at companies, at FDA. FDA has wonderfully set up this fast path for an emergency access request, started in oncology and has spread to other areas as well. And that, again, in our Barth syndrome population is what's quite frequently used. So FDA has granted emergency use access for our drug, elameprotide, for Barth syndrome, but has yet to say that that same risk-benefit profile can apply to the general population of patients with Barth syndrome. Where's the ethics? What are the ethics surrounding those two different kinds of decisions?
Good luck. Who wants to handle that?
You need an ethicist for that, so.
Okay.
I was going to call on Richard again for the FDA point. Yeah.
Well, you know, we're going to run out of time.
We're
so
actually out of time.
somebody take a
Just
shot
putting
at
it out
It
there
is,
that,
it is
that-
something that we hear a lot, and all I can say is that it's the non-monolithic nature of these considerations, the case by case basis. I will say, not as a, you know, an FDA cheerleader, although I do have some fondness for many of its members. If you look at the N of 1 for ultra rare diseases and the ones that have been developed, the FDA was on board from the very beginning there. And that's, I mean, that indicates like some sort of flexibility. But the question you ask is something that we hear a lot, like, if it's okay here, why not here? I don't have the answer.
Yeah, and I also would like to punctuate what you said. There's a lack of alignment sometimes between the inclusion-exclusion criteria for a trial, what the FDA ultimately approves the product for, that doesn't always align with the exact population that the trial was tested, that the product was tested in. And the payer might have a slightly different population that it will reimburse. And it wouldn't surprise me then that the expanded access program would be also a different population. I haven't seen enough studies showing the discord across these different gatekeepers and raising the question of what should that look like, and should there be greater harmonization? If so, when and where and when not?
Thank you.
And I can help you with your physician question. We can talk at the break. Unfortunately, we're out of time, so thank you so much to the panelists.